Learning outcomes. After studying this module, you shall be able to learn about the various cerebrovascular diseases including stroke, ischemic attacks and hemorrhagic disorder. Learn about the cerebral arterial systems. Learn about the risk factors predisposing stroke. Learn about the investigation and treatment of stroke. Learn about subarachnoid haemorrhage. Introduction. Cerebrovascular diseases are a group of conditions that affect the circulation of blood to the brain. They cause limited or no blood supply to some areas of the brain. Cerebrovascular disorders account for the third major cause of death after heart attack and heart diseases and cancer in the developed countries. Cerebrovascular diseases, CVD, is the second most common cause of cognitive impairment after Alzheimer's disease. A cerebrovascular accident is the medical term for a stroke. CVD is the most disabling of all neurological diseases. Approximately 50% of the survivors have a residual neurologic deficit and greater than 25% require chronic care. The CVD includes some of the most common and devastating disorders: ischemic stroke, hemorrhagic stroke, and cerebrovascular anomalies such as intracranial aneurysms and arteriovenous malformations, AVMs. They cause 200,000 deaths each year in the United States and are a major cause of disability. The incidence of cerebrovascular diseases increases with age. Most cerebrovascular diseases are manifest by the abrupt onset of a focal neurological deficit, as if the patient was struck by the hand of God. In some countries, such as Japan, CVD is more common than Alzheimer's disease. The CVD occurs more rarely in younger people due to conditions such as syphilis that lead to artery damage and strokes. CVD is characterized by occlusions by an embolus, any detached traveling intravascular mass carried by circulation, thrombus, blood clot, or cerebrovascular hemorrhage or vasospasm, resulting in ischemia, restriction in blood supply to tissues of the brain tissues. The sequel of a cerebrovascular insult depends on the location and extent of ischemia. Paralysis, weakness, sensory change, speech defect, aphasia, or death may occur. In the United States, 80% of the cerebrovascular incidents are ischemic and 20% are hemorrhagic. It may sometimes also be referred to as brain attack. Cerebral arterial system. Cerebral arterial system involved in CVD are classified into following: carotid system and vertebrovascular system. The carotid system consists of two internal carotid arteries. The vertebrobasilar system consists of two vertebral arteries which join two from the basilar artery. The two arterial systems join by the way of anastomosis to form circle of Willis, which is situated at the base of the brain. The internal carotids give off two anterior cerebral arteries which are joined by a single anterior communicating artery. The basilar artery divides into posterior cerebral arteries which are united with two internal carotids by the posterior communicating arteries. The circle is thus completed. Arteries of the cerebral hemisphere. 1. Internal carotid artery. The internal carotid artery, after entering the cranium, gives an ophthalmic branch which supplies the retina via the central artery. The anterior carotid artery, a branch of internal carotid artery, supplies the choroid plexus of the lateral ventricle. Second, anterior cerebral artery. It is a branch of the internal carotid artery. It gives off basal branches, one of which is recurrent branch, which supplies a part of internal capsule and basal ganglia. Anterior communicating artery, which unites the two anterior cerebral arteries, and cortical branches to the frontal and the parietal lobes, which supply medial part to the hemisphere and a part of lateral part of the cerebral hemispheres. Third, middle cerebral artery. It is a branch of the internal carotid artery which supplies the major parts of the cerebral hemispheres. A striate branch supplies corpus striatum and parts of both anterior and posterior limbs of the internal capsule. Cortical branches consists of the orbital and frontal arteries which supply the inferior and middle frontal gyri. Fourth, posterior cerebral artery. The two posterior cerebral arteries are the terminal branches of the basilar artery. They give off basal branches which supply thalamus, 2/3 of crus cerebri and red nucleus. Posterior choroid artery, 2 in number, supply thalamus, brainstem and third and lateral ventricles. Cortical branches, 4 in number, supply uncus, calcarean sulcus and visual area of the cortex, part of medial surface of temporal and occipital lobe. Clinical significance of the arteries. The partial occlusion of the carotid arterial system leads to transient ischemic attacks, TIAs. Second, the circle of Willis is the site of congenital aneurysms at the bifurcation of the major arteries. The rupture of an aneurysm may lead to haemorrhage. Third, the thrombosis of anterior cerebral artery might lead to paraplegia. Fourth, the middle cerebral artery is the main culprit vessel in a patient of hemiplegia. A branch of middle cerebral artery supplying the internal capsule is the common site of hemorrhage leading to hemiplegia. Fifth, the occlusion of a small perforating branch leads to small area of infarction which may or may not be picked up by the CT scan, called a lacunar or small vessel infarct. For example, a lacunar infarct can lead to pure motor or pure sensory hemiplegia. Cerebrovascular disease, stroke. Stroke is defined as a focal neurological deficit due to vascular lesion or occlusions. It is usually of rapid onset and lasts longer than 24 hours if the patient survives. Hemiplegia, paralysis of one half of the body, is a common manifestation of stroke. A completed stroke is defined as maximum neurological deficit developing within 6 hours of onset and lasts for days and weeks. A stroke in evolution is defined as a condition where symptoms and signs of neurological injury are getting worse within 24 hours of the onset. Transient ischemic attack is a focal neurologic deficit lasting for less than 24 hours. There is complete recovery. Classification of stroke. The three major classes of stroke are: 1. An ischemic stroke. This type of stroke occurs when there is cerebral infarction, ischemia due to cerebral thrombosis and embolism. Second, a hemorrhagic stroke. It is caused by an intracerebral hemorrhage. Ruptured aneurysm is the cause in the young in particular. 3. Lacunar infarct. These are small deep cerebral infarcts produced by occlusions of a small perforating artery due to lipohyalurosis, also called small vessel infarcts. There are various classification systems for the subtypes of ischemic strokes, each with their own strengths and weaknesses. Some of the most commonly used systems include Stroke Data Bank Classification, derived from the Harvard Stroke Registry Classification. The National Institute of Neurological Disorders and Stroke, NINDS, recognized the following major groups: infarction of unknown cause, infarction with normal angiogram, infarction with association with arterial pathology, embolism from a cardiac source, infarction due to arteriosclerosis, lacunae infarct, parenchymatous or intracerebral hemorrhage, all other strokes. The Oxford Community Stroke Project Classification, OCSP, also known as the Bamford-Oxford Classification. It relies primarily on the initial symptoms. Based on the extent of the symptoms, the stroke episodes is classified as total anterior circulation stroke, TAC, partial anterior circulation stroke, PAC, lacunar stroke, LAC, posterior circulation stroke, POC. The type of stroke is then coded by adding a final letter to the above. 1. I for infarct, example TACI. Second, H for hemorrhage, example TACH. 3. S for syndrome, intermediate pathogenesis prior to imaging, example TACS, etc. These predict the extent of the stroke, the area of the brain affected, the underlying cause, and the prognosis. The TOAST, Trial of Organization 10172, in acute stroke treatment classification. It is based on clinical symptoms as well as results of further investigations. Based on this, a stroke is classified as being due to thrombosis or embolism due to arteriosclerosis of a large artery, embolism of cardiac origin, occlusion of a small blood vessel, other determined causes, underdetermined cause such as following: 2 possible causes, no cause identified, incomplete investigation. Determination of the subtype is important when classifying patients for therapeutic decision making in daily practice, describing patients' characteristic in a clinical trial, grouping patients in an epidemiological study, careful phenotyping of a patient in a genetic study. Predisposing conditions and risk factors. Although they are more common in older adults, strokes can occur at any age. Stroke prevention can help reduce disability and death caused by the disease. Controllable or treatable risk factors for stroke include smoking. Incidence of stroke can be reduced in an individual by quitting smoking. There is recent evidence that even long-term second-hand smoking exposure may increase the risk of stroke. Hypertension, which is high blood pressure. Blood pressure of 140 by 90 mm Hg or higher is most important risk factor for stroke. Controlling blood pressure is crucial to stroke prevention. Carotid or other artery diseases. The carotid artery in neck supply blood to the brain. A carotid artery narrowed by fatty deposits form arteriosclerosis, that is, plaque built up in the artery walls, may become blocked by a blood clot. History of a transient ischemic attack, TIA. Diabetes. It is crucial to control blood sugar levels, blood pressure and cholesterol levels. Diabetes, especially when untreated, puts an individual at greater risk of stroke and has many other serious health implications. High blood cholesterol. A high level of total cholesterol in the blood, that is 240 mg by dl or higher, is a major risk factor for heart diseases, which raises risk of stroke. Physical inactivity and obesity. Being inactive, obese or both can increase risk of high blood pressure, high blood cholesterol, diabetes, heart diseases and stroke. Recent researches show evidence that people receiving hormone replacement therapy, HRT, have an overall 29% increased risk of stroke, in particular ischemic stroke. Uncontrollable risk factors include age. People of all ages including children have strokes, but the older suffer from greater risk of stroke. Gender. Stroke is more common in men than in women. Heredity and race. One has a greater risk of stroke if a parent, grandparent, sister or brother has had a stroke. Blacks have a much higher risk of death from a stroke than Caucasians do, partly because they are more prone to having high blood pressure, diabetes and obesity. Prior stroke or heart attack. If a person has had already a stroke, he is at a much higher risk of having another one. If he has had a heart attack, even then he is at a higher risk of having a stroke. Ischemic stroke. Ischemic stroke is a stroke with cerebral infarction, ischemia due to cerebral thrombosis and embolism. Transient ischemic attacks, TIAs. These are defined as episodes of temporary and focal cerebral dysfunction of vascular region leaving no persistent neurological deficit and lasting for less than 24 hours. The episodes may be isolated and infrequent, or they may occur many times in a day. They tend to be consistent in their symptomatology in an affected individual, suggesting the involvement of the same side of the brain. These attacks do not cause irreversible infarction, hence recovery is the rule. In TIA, An artery to the brain is temporarily blocked, causing stroke-like symptoms, but the blockage dislodges before any permanent damage occurs. Symptoms of a TIA may be similar to a stroke, but they resolve quickly. In fact, symptoms may be so vague and fleeting that people just brush them off, especially when they last just a few minutes. Attacks are more common in old persons due to arteriosclerosis of carotid vertebro-basilar systems. Symptoms due to carotid system insufficiency can be listed as amaurosis fugax, sudden transient loss of vision in one eye due to remobilization of retinal artery, aphasia, disturbance of speech, hemiparesis, weakness on one side of the body, hemianesthesia and analgesia, hemianopic, visual loss, loss of one part of the visual field. Symptoms due to vertebra-basilar system insufficiency are the following: diplopia, double vision, vertigo, vomiting, dysarthria, ataxia, disturbance of gait, hemianesthesia and analgesia, hemianopic, visual loss, transient global amnesia, loss of memory, quadriparesis, weakness of all four limbs, disturbed consciousness, which is rare. Cerebral thrombosis. Cerebral thrombosis is one of the most common types of stroke. This condition occurs when a clot of blood forms locally in one of the arteries of the body that supplies the brain. The clot actually blocks the artery and keeps it from functioning. This creates a similar yet differentiated condition from cerebral embolism, which is another form of the stroke. Like a cerebral embolism, however, the effect is the cutting off the nutrition and blood flow from one part of the brain. The formation of a blood clot in a cerebral vessel ordinarily takes place only if there has been damage to one or more of the arteries. This is usually caused by a condition called arteriosclerosis. The vessel may be degenerated, hardened, or otherwise damaged. This is one of the reasons that cerebral thrombosis occurs in elderly people and the individuals who have problem with known high blood pressure and a hardening of the arteries. Cerebral thrombosis often occurs at night or in the early morning hours when the blood pressure is low. This condition is often preceded by one or more mini strokes heralding the condition. Symptoms will depend on how large the vessel and the clot are. If one of the main arteries supplying the brain is blocked, then the individual affected may lose consciousness and be paralyzed on one side of the body. This would also result in loss of speech if the left cerebral hemisphere is affected. Symptoms may resemble those of cerebral embolism, but the onset will be less sudden, may include warning signs and a period of time lasting up to a few hours, where the individual will feel faint, dizzy, and potentially have a headache. However, this condition also tends to occur when a person is resting or sleeping, as mentioned earlier. If the thrombosis is a very small one in one of the smaller arteries, symptoms may be relatively mild and may be barely noticed by the individual. The prognosis for recovery from small cerebral thrombosis is very good, and full functioning may be restored within a matter of a day or weeks. In much more severe cases, when a large part of the brain hemisphere is affected, an individual may take much longer to recover or may remain paralyzed or affected by some degree of mental impairment. For those individuals who have problems with arteriosclerosis, hardening of the arteries, or high blood pressure, or those who have had mini or warning strokes may require surgery or medication or a combination of both types of treatment. Other types of infarcts. Other than ischemic stroke, there are other types of infarctions also. These can be enumerated as the following. 1. Lacunar or small vessel infarct. Lacunae are small, which is less than 1.5 cm square area of infarction seen at post-mortem in patients with hypertension. These are due to occlusion of a perforating branch of a vessel due to lipohyalinosis of intimae, which is deposition of hyaline in an intimae layer of blood vessel, or a perforated small artery. Pure motor or pure sensory stroke ataxis hemiparesis, sudden dysarthria with clumsy hand syndrome is some of the example. Lacunar infarcts may be symptomless at times. Second, multi-infarct dementia. Multiple small infarcts or larger infarcts cause generalized intellectual or memory loss. That is, sometimes seen in patients with CVD. The condition evolves with a stepwise progression of symptoms with each subsequent infarct. The final picture evolved includes dementia, pseudobulbar palsy, and short shuffling gait of Parkinsonism. 3. Watershed infarction. This implies multiple cortical infarcts following profound shock or hypertension due to massive myocardial infarction or massive GI bleed or hypertensive therapy. The border zones between the areas supplied by anterior, middle and posterior cerebral arteries are damaged. A syndrome of cortical visual loss, memory loss and intellectual impairment results due to it. In several cases, there may be a persistent vegetative state. Investigations and treatment. The preliminary investigations done in a patient of stroke are urine analysis and blood glucose for diabetes mellitus, hemoglobin, platelets and PCV, that is packed cell volume, WBC count for evidence of infection, ESR and C-reactive protein for inflammation, serological tests for neurosyphilis, X-ray test for any growth or tuberculosis, ECG for evidence of infarct, ventricular aneurysm and arrhythmias, anti-nuclear factor, double-stranded DNA, anti-phospholipid antibodies and homocysteine levels for stroke in the younger patients, blood culture and echocardiogram EEG for patients with underlying heart diseases. Further cerebrovascular specific investigations include cerebrospinal fluid examination. It is done for inflammatory diseases of brain or for hemorrhage infarct. It is useful in 80% of the cases of hemorrhagic strokes and in 90% of subarachnoid hemorrhage where CFS contains blood. CT scan. This is indicated in all patients with stroke and TIAs. CT scan can differentiate between hemorrhage and an infarction and can also detect surrounding edema, that is swelling. However, a CT scan cannot differentiate between normal tissue and early ischemic tissue, nor can it detect cases of early infarction, which is less than 48 hours. CT scan with angiography, which is contrast CT scan, will differentiate enhancing from non-enhancing lesions. Carotid Doppler study. This is a valuable screening test for carotid artery disease. Cerebral angiography, MR angiography or digital subtraction angiography are more useful than Doppler study to define the cerebral microvasculature, areas of stenosis and ulcerated athominous lesions. Magnetic resource imaging, MRI. It is a supplement to CT scan. MRI often visualizes anoxis lesions missed by CT. It is useful in making early diagnosis in patients with normal CT. Treatment. Goals of therapy. To save life and to speed up recovery. Rehabilitation of physical and occupational therapies for gainful employment. To prevent reoccurrence. To remove the cause if possible. General measures. In acute stroke or hemiplegia, maintenance of vital signs, patient airway, fluid and electrolyte balance, and prevention of complications are mandatory. Ventilation. Patient airway must be maintained to prevent accidental aspiration and for continued suction of trachobronchial secretions. Oxygen administration. Oxygen is administered via nasal prongs or mask. It is necessary in case of hypoxia. Blood pressure in acute stage of cerebral ischemia. In fact, blood pressure should not be lowered unless there is moderate to severe hypertension that persists despite medical treatment. On the other hand, in hypertensive CVA with encephalopathy, changes in oxygen levels in the brain or malignant hypertension, measures must be employed to reduce the blood pressure. Fluid and electrolyte balance. Restriction of fluid intake during the first 2-3 days or even a negative balance is beneficial to reduce cerebral edema. reduction of cerebral edema and increased intracranial pressure, lipid lowering agents for hyperlipidemia. Specific therapy. It is directed against the cause and to prevent recurrence and complications. Antiplatelet agents. Antiplatelet agents are used either alone or in combination to inhibit platelet aggregation and useful in cerebral thrombotic infarction, embolism and transitory ischemic episodes. Aspirin is widely used for primary and secondary prevention of strokes. Thrombolysis. Intravenous thrombolytic therapy is effective in reducing the neurological deficit in selected patients without CT evidence of hemorrhage when administered within 3 hours of stroke, provided there is no contraindication. Anticoagulants. The role of anticoagulants in complete stroke is doubtful and often fraught with dangers. They are used when there is involvement of heart. Danger. A diagnosis of ischemic infarct must be confirmed on CT and CSF examination before start of anticoagulant therapy, otherwise hemorrhage complications will pose a danger. Surgical treatment. Carotid endarterectomy remains the usual therapy for TIAs caused by carotid stenosis. Extracranial to intracranial bypass surgery is necessary in symptomatic patients with distal occlusions of either internal carotid or middle cerebral artery. Recently, a percutaneous angioplasty with stent has been tried in carotid artery stenosis with good results. Physiotherapy and rehabilitation. Physiotherapy is useful in the first few months after stroke. Aims of physiotherapy: to relieve spasticity, contractures, to teach patients to use walking aids, to bring the patient in mainstream of life and suggest useful means of employment, to keep self-esteem and to prevent psychological upset. Treatment in specialized unit and well-organized outpatient physiotherapy and occupation therapy after discharge improves outcome. Speech therapy. An aphasic patient hastens the return of speech. Special attention is to be given to shoulder pain, immobility in hemiplegic patients. With appropriate and intensive treatment, many patients with stroke can resume useful life and employment despite residual disability. Subarachnoid hemorrhage. Spontaneous bleeding into subarachnoid space is called subarachnoid, which is the space between the layers of the brain, hemorrhage, which may be primary due to rupture of vein or artery or secondary due to leakage of intracerebral hemorrhage into the ventricles. Causes: rupture of cerebral aneurysm. Aneurysm is an abnormal balloon-like bulging of the wall of an artery. An arteriovenous malformation, leakage of intracerebral hemorrhage, hemorrhagic cerebral infarction, bleeding disorders like leukemia, clotting disorders like hemophilia, head injury with fracture of skull. Clinical symptoms and features. Most aneurysms rupture without warning symptoms such as headache. Common symptoms are neck rigidity, pyrexia, which is fever, irregular breathing, transient hypertension and bradycardia, which is low heart rate, pre-retinal hemorrhage, confusion, restlessness, memory loss, disorientation, headache, vomiting, sixth nerve palsy, retinal edema. The headache at the time or immediately after the rupture is so severe that the patient describes it as the worst headache of life. Management. Investigations used for diagnosing subarachnoid hemorrhage are CSF examination, cerebral angiography, CT scan, MRI, ECG, etc. Severe bursting headache, brief period of unconsciousness or restlessness with confusion and disorientation, lack of localized neurological signs, presence of neck rigidity in young normotensive individuals form diagnostic clues to subarachnoid hemorrhage. Treatment: absolute bed rest for the first 3 to 4 weeks. All sorts of physical strains must be avoided, coughing, sneezing, etc. Blood pressure must be controlled. For severe headaches or neck pain, mild sedation can be used. Prophylactic anticonvulsants may be used. Seizures may raise blood pressure, may promote rebleeding. Decongestive therapy with osmotic agents to augment cerebral blood flow during vasospasm. Antifibrinolytic agents useful in the first 14 days in reducing the incidence of rebleeding but are associated with an increased incidence of cerebral infarction. Aneurysms, if accessible, should be clipped, should undergo endovascular treatment by interventional radiologists. Major cerebral infarction typically produces a stroke, but small infarcts may present as TIAs or may even be symptomless. The clinical picture is highly variable and depends on the site and the extent of the infarct. When stroke evolves in a stepwise fashion, that is, stroke in evolution, the symptom may appear in each limb in succession or simultaneously. This shuttering or intermittent manifestation is characteristic of cerebral thrombosis. The most common stroke is hemiplegic, caused by infarction of internal capsule. Summary. Cerebrovascular disorders are a group of conditions that affect the circulation of blood to the brain called cerebrovascular accident. Internal, anterior, middle and posterior arteries supply blood to the brain. The three major classes of stroke are an ischemic stroke, lacunar infarct and a hemorrhagic stroke. Several classifications can be suggested for cerebrovascular disorders. Cerebral thrombosis is one of the most common types of stroke. Lacunar or small vessels infarct, multi-infarct dementia, watershed infarction are other kinds of stroke. Smoking, hypertension, obesity, lack of exercise, diabetes are preconditions for stroke. Repeat, carotid endarterectomy, extracranial to intracranial bypass surgery symptomatic, precutaneous angioplasty with stent has been tried in carotid artery stenosis with good results.